I changed the title a little bit to be more epilepsy in the older adults, as the elderly is a quite I'm not sure that what all the considerations are what we would typically consider elderly, and it often these start around the age of 50 or a little bit over that, which many people now are not considering so elderly anymore. So just to go over, I have no disclosures relevant for this presentation. And I have two main, very broad learning objectives for this talk today, looking at incidence, etiologies, and risk factors for new onset epilepsy in the older adult, and a little bit of emphasis on epilepsy related to stroke and neurodegenerative diseases, as these are the most common etiologies, as well as some of the special considerations for treatment in the older adult, as there are some additional things to consider when you're looking at these people. So just a quick review, looking at the distribution of epilepsy by age, the epilepsy is highest in the older adult population. It's a bimodal distribution, with the highest ones being greatest in children and the older adults. The incidence, again, is quite high compared to the rest of the population. So in general, it's between 0.6 and 1%, and those over 65 is at least 2.4%. And with that, the risk also increases depending on a variety of risk factors. The older you are, the more likely it is that you're going to have epilepsy. There's also some association with Black heritage, as well as stroke in particular. So the etiologies of stroke are a little bit different in their distributions compared to that in a younger population. Stroke in general, but especially ischemic stroke is the most common etiology. Then you also have a fair number being associated to a variety of different neoplasms, both primary and metastatic, as well as Alzheimer's disease and other neurodegenerative diseases being the next most common causes of epilepsy in this population. And just this is the only mention I'm going to make of it in this presentation, but there is a bit of a difference when you're considering new onset epilepsy in this population versus chronic epilepsy in someone who's had epilepsy their entire life and they become an older adult. There's some different considerations that you would want to do with that, and some risk factors that are a little bit different, as well as the features of the epilepsies can be a little bit different when you look at them. That said, it's a bit of a different population, the chronic epilepsy people, so I'm not really going to spend a lot of time talking about that. We're going to mainly focus on the new onset epilepsy in the older adult today. So risk factors, the main risk factors associated with epilepsy in the older population are stroke and dementia, with being the most common. There's a few other ones that are a bit less, but still statistically significant. And a lot of those are just your stroke and dementia risk factors, like hypertension, smoking, and diabetes, as well as that ApoE4 allele, which can be a slightly higher risk as well. And this is from the atherosclerosis risk and community study, and there's a few different papers they've published now on the risk in late onset epilepsy and a variety of features associated with them. Moving on to epilepsy in people with dementia, it's again, in people with dementia, there's about a 10 to 17% risk of having epilepsy as a result of that. And most of that is with the risk related to Alzheimer's disease. And you're more likely to develop epilepsy both with a younger age of dementia onset and a longer duration of dementia. There's also some association with slightly higher predominance in men, but not necessarily, yes, a higher predominance of men. And then also with seizures, there is some association with a faster cognitive decline, and that's for a variety of reasons that are not fully understood, but may be related to amyloid and tau production and chronic compensatory remodeling, and then the effect of seizures themselves, particularly as Alzheimer's disease often affects the temporal lobes, and then they may have temporal lobe seizures, which then can increase your memory impairment as a result of the seizures. If you do prolonged EEG monitoring, so more than just your routine EEG, about 40% of Alzheimer's patients will have epileptiform abnormalities. And so that's not necessarily all of those who are definitely having clinical seizures, and maybe more of a reflection of an abnormal brain activity. So again, similar to what I said, looking at both seizures and myoclonus, which can be epileptic or may be subcortical. The longer you have the disease, the more likely you are to develop seizures and myoclonus. And then also looking at that, it also is the same for depending on what type of epilepsy you have, with it being the most in Alzheimer's and dementia with Lewy bodies, and the least in frontotemporal dementia. Again, the age thing is also is illustrated in the chart on the right, in that if it's younger onset between the ages of 30 and 49, certainly you'll have much higher risk of developing seizures, particularly early on, than if you have later onset Alzheimer's or other dementias. So do we know, can we diagnose epilepsy in early Alzheimer's disease? And this is a bit of a challenge because often people with the Alzheimer's disease have temporal lobe semiology, as this is often the primary and first area that is affected by neurodegeneration in Alzheimer's disease. And so there's impaired awareness. They may have drop attacks and unexplained falls, and then transient confusion and wandering in familiar places. And if you think about that, early Alzheimer's, that's also some of the things that you see that are a result of Alzheimer's disease itself. So it's sometimes a bit difficult to tease apart whether it's seizure or just ongoing cognitive decline. And another thing is that a small proportion, but definitely there, of people who are diagnosed with epilepsy around the same time as their cognitive decline. And so it can be a bit challenging to tease these people apart, particularly when it's early on in the disease. And so the subjective complaints may also be difficult to distinguish with that. And that's where some things like neuropsychological testing can come in handy. However, at times, this is again something that you need to have a bit more long-term follow-up on, as if it's early in Alzheimer's disease, sometimes you can see similar neurocognitive changes to that seen in late onset temporal lobe epilepsy. So it can be quite challenging to make this diagnosis in this population. So a high degree of clinical suspicion is needed for these people. And looking at possible mechanisms, this is I thought was a nice chart, looking at what happens over the course of Alzheimer's disease and how much amyloid and tau starts to be deposited, which eventually, once you start getting the hippocampal hyperactivation, that kind of precipitates cognitive changes. Once that hits a certain point, you may be more likely to have Alzheimer's disease, but then the interictal and the epileptiform activity and the chances for epileptiform activity are much higher as well. Okay, and just a word on acetylcholinesterase inhibitors and seizures. You'll hear particularly in geriatrics that people who have seizures are not started on acetylcholinesterase inhibitors or tried not to be started on acetylcholinesterase inhibitors if they have epilepsy or if they've had a seizure while taking an acetylcholinesterase inhibitor, and then they'll stop it. This is a recent study that just came out looking at all of the different main acetylcholinesterase inhibitors as well as memantine, and looking at the risk of having seizures in relation to starting the drugs. So you can see here, looking at the timing is over a year's time, and overall there's a slightly higher chance at a year of having a chance of seizures, but not before that. So it's probably not as significant an issue as was previously thought. The other thing to consider is that if the acetylcholinesterase inhibitor is working and giving them some cognitive benefit, seizures in Alzheimer's disease are usually fairly easy to control, and it may be worth just adding an anti-seizure medication if they're getting some benefit from the only treatment we have available right now for Alzheimer's disease. There are enzyme inducers, as with most other things related to enzyme inducers, have a bunch of drug interactions with these medications, but most of the newer medications do not have drug interactions, and so you should be okay with using anything besides an enzyme inducer. Okay, so that's dementia. Stroke, there's two main things to consider in stroke-related seizures, and those are the initial acute symptomatic seizures related to the initial stroke itself, as well as the late onset seizures that have a much higher predisposition to ongoing seizures and are then diagnosed as epilepsy. The mechanisms, as you can see here, are somewhat different in generating the seizure, with the acute ones more relating to the acute insult that's going on in the brain, which may be hypoxia related, and may be due to changes in neurotransmitters as a result of a breakdown of cells. The ions channels are dysfunctioning with them, and then if there's any hemorrhage with it, it's also very irritable and can potentially cause a seizure as a result of that. So those seizures are not usually considered in the same likelihood of having further seizures as late seizures are. And so generally it's a bit of an arbitrary number, but about 7 days after the initial insult is when that first process is mainly taking place and is the likely cause of the seizure, versus the later period when you're more likely to have it as an ongoing issue. And that's related to, as you can see there, more of the chronic issues, scarring related to the previous stroke, as well as other neural regeneration neuroregeneration that may cause some aberrant connections and alterations that may predispose someone to developing more seizures. So those are the ones that we tend to focus on more, because those are the ones that we need to treat on a long-term basis. And for stroke-related epilepsy, it's about 50% of the causes of new-onset epilepsy in people who are older than 60. That said, within the population who develops epilepsy with stroke, it's anywhere between 1% and 20%. It depends on the study and how they've included people with it, and certainly there's a wide range depending on the different study as to what the actual incidence is. So it's not clear, but it's somewhere in that range. It is much less common to develop refractory epilepsy than it is in those within a younger population and due to other etiologies. If you're going to have epilepsy as a result of your stroke, it's much more common in people who are younger, people who have severe neurological deficits on their initial presentation, so it looks like a big stroke. If there's greater cortical involvement, as well as after the, once you have the chronic remodeling as a result of stroke, if you see those little cortical islands Amongst all the encephalomalacic tissue, that's often an indicator that you're more likely to have seizures. The size of the lesion being bigger, more likely to have seizures, as well as some of the locations with them. Those are all within the middle cerebral artery territory, the parietal temporal cortex, supramarginal gyrus, and superior temporal gyrus. But those seem to be some of the more common areas that people will develop epilepsy if they've had a stroke in the past. Then just looking at acute to symptomatic seizures, there's been it's a bit limited in terms of what research has been done for it, but at present there's no role for prophylaxis to prevent seizures in someone who's had a large cortical stroke when they are first admitted to hospital. And so there's been a number of studies that are ongoing, and the data is not completely clear yet about whether statins can be helpful in terms of neuroprotection. They overall are felt to have a neuroprotective effect, but there are also some thoughts that they might be effective in preventing early post-stroke seizures. But the data is not completely clear on that, and it varies quite a bit. In general, though, if they have a single seizure or a couple of seizures, abortive therapy is generally indicated. There's not necessarily a need to start anti-seizure medications unless they're having a lot of difficulties with the seizure. They go into status. You might consider doing a short-term treatment trial with anti-seizure medications, but probably only for a month or two, as the risk of developing epilepsy following these acute symptomatic seizures is much lower, given the differing etiology of why they are having the seizures. Okay, so treatment considerations, and this is really the main clinically relevant part of treating this population, is that there are a lot of things to consider in this population. So age-related changes in drug metabolism, polypharmacy, side effects, comorbidities, their falls risk, as well as vascular risk associated with these. So a number of age-related changes in drug metabolism, including decreased hepatic function, which can be from blood flow, or decreased protein binding, so there is more free fraction of anti-seizure medications available. There's decreased renal clearance, also, which increases the amount of drug that's available to the patient. And there is also decreased gastrointestinal absorption of them, so they might not be getting as much of it as initially as the population who's got more normal function and is a bit younger. So drug metabolism is an important consideration in this group. The therapeutic window narrows significantly once you become older, and this is the case for any medication. So you have less of a therapeutic range to work with, so you have a bit of a smaller dose range before someone will become symptomatic from side effects from these medications than you do in an older, or sorry, than in a younger population. The other thing to consider is specifically phenytoin, which hopefully most people are not using in this population as much anymore, but phenytoin has zero order kinetics, and there's that nice the logarithmic scale of metabolism and availability, which gives you your therapeutic window. This curve is even steeper in the elderly, so it gives you an even narrower range to work with when using this medication to treat this population. Looking at a couple of the other newer medications, overall, most medications have some degree of decrease in their metabolism of these medications, which varies depending on the person, and also varies based on some of their other comorbidities, which we'll get into a little bit in a second. So polypharmacy is also an important issue to consider. And this mainly relates to drug-drug interactions. And there are some drugs that are more bigger offenders in this than others, and are important considerations to consider with that. So going back, looking at your strong enzyme inducers, ones that are going to significantly change levels of other medications are carbamazepine, phenytoin, phenobarbital, and primidone. So generally the older, classically enzyme-inducing anti-seizure medications. There's also a few that are weak enzyme inducers, and some of these are dose-related, particularly topiramate, perampanel, and acetylcarbazepine. The higher the dose, the more likely they are to produce some enzyme induction. And oxcarbazepine and acetylcarbazepine are also, and clobazam also have some degree of enzyme induction. And then there are a few enzyme inhibitors which can be clinically relevant as well. And oxcarbazepine and acetylcarbazepine have a little bit of enzyme induction as well as inhibition, depending on the CYP450 enzyme being looked at. Valproic acid is also the other one that's sometimes significant in terms of enzyme inhibitors. So this is a giant list. I'm not going to go into it at all, but just to say all of the medications, or some of the medications that can be associated with changes with enzyme-inducing medications. And if you kind of look at that, there's a lot of medications that are frequently used in this patient population for stroke prevention or other cardiac disease prevention, and management of cardiovascular conditions. Other medical comorbidities are also important to consider with this, and particularly renal disease, hepatic disease, as those change the drug interactions, cardiac disease, also for a number of reasons, other neurological conditions which may affect your drugs or your drug choices, as well as cancer, which is mainly due to interactions with other medications. And so this is also another important place to look at the pharmacokinetics of these medications and looking at how they are eliminated in selecting your choices through that as well. So particularly with the hepatic and the renal diseases, you want to avoid the ones that are either primarily hepatic or primarily renally excreted, if they have that kind of if they have either hepatic or renal dysfunction. And so in renal disease, the main medications that are renally eliminated, or the ones that are important to consider when looking at renal disease, are levetiracetam, gabapentin and pregabalin, topiramate, sorry for the spelling mistake there, acetylcarbazepine, lacosamide, and vigabatrin, which is probably not going to be used very often. And there's a few things that happen with these. The decreased renal clearance in these patients causes an increased half-life of the medication. So there's going to be more accumulation of the medication in the blood, and can be more likely they can be more likely to develop toxicity as a result of them. The other thing to consider is that there's becoming more evidence that some non-renally eliminated seizure medications, their pharmacokinetics are also altered by renal disease, particularly those that are highly protein bound, as with chronic disease, your albumin decreases, and then any of the protein bound medications are going to be more freely available. There's also some evidence that chronic kidney disease can affect some of the CYP450 enzyme expression and drugs transporters, which may also affect some of the drug levels and amount that the patient is getting. So often the dosing can be altered based on your creatinine clearance and whether they're on dialysis or not. Often with dialysis, you will need a supplement, and the most medications and monographs have pretty clear instructions on dosing in renal disease. There's a nice chart here. I'm going to just leave it up there for people to look at. I'm not going to go over it in great detail, but it's a nice summary of what you need to, how you need to change it the medication doses depending on the patient's renal function. But just a couple of things to highlight. These medications, brivaracetam, carbamazepine, clobazam, phenytoin, and valproic acid, in general, do not require any dose adjustments in patients with renal disease, and there's nothing you need to do extra for if they are undergoing hemodialysis. So those are nice ones to keep in mind for that reason. Okay. Another thing to consider is that seizures are common in renal disease, and seizures not all seizures are epileptic and have an ongoing predisposition. So you want to make sure, particularly in someone who has end-stage renal disease and is presenting with a first seizure, that it's not provoked by some other cause. And lots of metabolic derangements occur in people with chronic renal disease, particularly those on dialysis. That could potentially be a cause of their seizure. Dialysis disequilibrium syndrome is something that can cause seizures, and is something to consider, particularly in someone who's had a seizure or an event that's suspicious for a seizure shortly after or during dialysis. And this is particularly common if someone has recently initiated dialysis, or they've had a more aggressive dialysis run, and more ultrafiltration has occurred. The other thing that can happen is you can get a uremic encephalopathy, and that may cause something that may or not be seizures, but certainly can sometimes be confused for seizures, given that they're encephalopathic and confused more so than normal. In liver disease, again, similar to renal disease, they often have provoked seizures. Again, also they may have metabolic derangements, which are a bit different, but still potentially can cause seizures. And then again, your hepatic encephalopathy, which can either result in seizures, although not common, or just a state of confusion that people may wonder as to whether it could be something like a non-convulsive status epilepticus. And for these patients, if possible, it's best to use a primarily renally eliminated medication so that you don't potentially worsen their liver disease. So side effects are have slightly different considerations in this population than in the younger population. Overall, the side effects are all the same, but there are different things to consider in this population given their comorbidities. And some of the ones in particular with this population that you want to think about are somnolence and impaired balance, as these are sometimes frailer individuals and maybe more sensitive to these side effects. And so you want to be aware of that when you're selecting one, as well as when they're telling you that they're having difficulties with somnolence or impaired balance. I have one patient who develops impaired balance once we get too high on a dose of pretty much any seizure medication that we've tried. So it can be elderly patients can metabolize and use drugs differently and result in different side effects than you would typically see in a younger population. The other things to consider, and thankfully there are not very many medications in this criteria, in this list, are the Beers criteria medications, which is the Beers criteria are a list of medications that should be avoided if possible in the elderly population due to risks of causing confusion and falls and other difficulties that may be preventable. So in here is benzodiazepines, either for acute abortion or something like clobazam, and then your barbiturates, so that phenobarbital or primidone. Again, hopefully not used all that often in this population, but something to be aware of, particularly if they're using lots of other medications on that list. And otherwise, things to consider a little bit more significantly in this population is that lacosamide can result in heart block, and lamotrigine is also now has a more significant warning about cardiac arrhythmias. It's still a little bit unclear as to the nature of this and how significant that risk really is, but at the same time, it does have that risk on the box now, and something to consider in patients who have underlying cardiac disease. The encephalopathy you see with valproate is sometimes more prominent, and particularly at lower doses than in those in the elderly. So it might be more problematic to use. Topiramate can cause metabolic acidosis, not typically seen in those who are younger, but much more common in those who are older, particularly in those who are taking other medications that might predispose them to this. So something to consider. And this is not just for starting medications. If they develop some sort of funny side effects as a result, that may be something to consider with these. And then, of course, the behavioral changes of levetiracetam and brivaracetam. One of the interesting things that I found over the last several years is that sometimes there is a few patients, older patients, who are much more sensitive to the somnolence with levetiracetam, and certainly you can see that a lot more in the older population at lower doses than you do in the younger population. And then the other thing to consider is the risks of hyponatremia with carbamazepine and oxcarbazepine in particular. And these patients are also often taking other medications that can predispose to hyponatremia, particularly diuretics, which may be more likely for them to develop it. So something to keep a closer eye on. Managing comorbidities is also something that can be helpful, and you can use these medications in patients who are often already taking multiple medications to try and decrease their medication burden by co-treating some of these other things with that. So peripheral neuropathy and chronic pain, you can use pregabalin, gabapentin, or carbamazepine. There's a few other ones off-label, oxcarbazepine, glucosamide, that might be effective for that as well, but not as well understood. Migraine headaches, you can use topiramate and valproic acid. Valproic acid is not as contraindicated in this population, as these are females are not of childbearing age anymore. Mood disorders, you can use lamotrigine or valproic acid, can sometimes be helpful to co-manage those. Essential tremor can also be helpful with to co-manage with gabapentin and primidone. And then if there's restless legs, gabapentin might be a good medication to choose and to try and decrease the polypharmacy if possible for these medications. Another thing to consider in this group is that they do have an increased risk of fractures in general. And so there's felt that there's an increased risk of falls as a result of seizure, and falling in as an older adult is a more significant problem. And often the falls as a result of seizures are more significant given the force of that someone falls with during a bilateral tonic-clonic seizure. This can also be increased with enzyme-inducing anti-seizure medications causing osteopenia, as well as from side effects of the medications, not so much directly, but more in causing a confusion or encephalopathy, whether they're getting diplopia or some blurry vision, and dizziness are also all common side effects of anti-seizure medications, which can increase someone's risk of falls and having a fracture. The other thing is that the risk of osteopenia, again, mostly with enzyme-inducing medications. The longer you use it, the more likely it is to occur, but it's also independently associated with these medications. And just to remind you, the classic and the main enzyme inducers are phenytoin and carbamazepine, the barbiturates, and to some degree valproic acid, although a little bit less. Vascular risk factors are an important thing to start considering, and more evidence has been coming out a lot over the last several years, both in for people who are mainly for enzyme-inducing anti-seizure medications, in that they can increase your cardiac risk factors and increase vascular risk overall, which is important in this population, which is already at risk of cardiac and vascular disease. The other thing that was found is that sometimes the enzyme-inducing medications can decrease the effectiveness of statins, so they don't lower the cholesterol as well as they would if they weren't taking that medication. And then the enzyme inducers also have an increased risk of dyslipidemia themselves. So it's not a great situation when you do that. The other thing to consider is that if you have uncontrolled hypertension or diabetes and hyper or hypoglycemia, you can also get provoked seizures from those. And then, as we mentioned before, there's also medication considerations and drug-drug interactions in the medications they use to control their vascular risk factors and some of the anti-seizure medications. So what evidence is there out there for what anti-seizure medications to use? And so, as you all know, there's been a huge increase in the number of anti-seizure medications over time, with some of the newer ones particularly having less drug-drug interactions and generally being better tolerated, which is potentially a very good thing in this population. Unfortunately, though, we don't have as much evidence specific to this population. There are 2 randomized controlled trials. This first one was done in 2005, looking at a combination, comparing lamotrigine, gabapentin, and carbamazepine. And what they found was that they were all essentially equally effective in treating seizures. However, carbamazepine was the least well tolerated, and lamotrigine was the best tolerated medication for this. And the doses, I can't remember off the top of my head what they were, but they were relatively low doses. I think the lamotrigine target dose was 150 milligrams per day. And the gabapentin dose was about 800 milligrams per day, and the carbamazepine dose, I think, was 400 per day. So they were relatively low doses too, that you can get away with in this population. Sorry, we'll skip that. There's also a newer study done 10 years later, looking at carbamazepine, lamotrigine, and levetiracetam. And again, similar results. They're all fairly equally tolerated, equally effective. But carbamazepine was the least well tolerated in this group. And lamotrigine and levetiracetam were fairly equally tolerated. So we have evidence for 4 anti-seizure medications. There's also recently a review done by, or a meta-analysis and systematic review done by some of our colleagues, looking at what evidence there is in terms of management of seizures in this population. And overall, levetiracetam seems to be a bit more effective than lamotrigine in terms of efficacy, but it seems to be equally effective to carbamazepine. But despite that, lamotrigine seems to be the best tolerated medication, and then levetiracetam and carbamazepine are fairly similar in their results. There's not a lot of other definite conclusions that can be made with this, that we're able to be made with this study. There's some trends with some of the medications, but there are not nothing definite at this point, and we don't have enough experience and time with the newer medications to know how effective they are. Ones we know of are levetiracetam, lamotrigine, carbamazepine, gabapentin. They all seem to work fairly well. Of those, probably carbamazepine is the least well tolerated of the group. And so here you go. There are a number of guidelines. Admittedly, they're old and came out before the most recent study. Overall, recommending lamotrigine or gabapentin as first-line treatment. Now, it would also likely be levetiracetam with this as preferable to something like carbamazepine. Okay. Oops, sorry. That is not what I meant to do. Okay. So the one last comment in that is epilepsy surgery an option if the patients were to become refractory? And overall, it's felt that yes, it is definitely an effective treatment for these patients, and it is as effective in this group of patients as it is in younger adults, and so definitely should be considered in the right patient population. However, there is a greater risk of complications because of surgery due to their older age and potentially as a result of some of their comorbidities. The risk of cognitive decline is also a bit higher as they do not have as much reserve as younger people to compensate for some of the potential cognitive changes as a result of surgery. But overall, people are very happy with it, and it has a good impact on quality of life as well as psychiatric comorbidities, which can be quite important in this population. So to summarize that, again, the highest incidence of epilepsy is in the elderly, and most common etiology is stroke, followed by neurodegenerative diseases. And in neurodegenerative diseases, also often seen early into the disease, particularly in those who are younger with age of onset. Altered drug metabolism in this population generally means that you want lower target doses of medications than in younger patients. You want to be aware of drug-drug interactions as they are common in this group, and particularly with the enzyme-inducing anti-seizure medications. And again, only a few randomized control trials have been done with the 4 medications, carbamazepine, lamotrigine, gabapentin, and levetiracetam, and they are all effective in controlling seizures. But of these, carbamazepine is the least well tolerated. And of course, epilepsy surgery should still be considered in these patients if they have refractory epilepsy, and could be a good surgical candidate. And that is all.
Great, thank you very much, Kristin. That was a very informative talk, and I think everyone will appreciate having access to that information, particularly about some of those interactions and things like hepatic and renal failure. I know that we had some issues with the chat earlier on. I don't see here that anyone from the audience has posted any questions, and I'm not sure if that's because there were none or if there's issues for the chat with them as well. I do have a question myself, and I do see that someone has raised their hand, but I don't believe that anyone is going to be able to turn on their mics and talk, which is why I really need you to post your question in the chat as opposed to raising your hand. And maybe you're raising your hands because you cannot post in the chat. I am not, unfortunately, I'm not sure about that. Okay, well, we do have someone here. Ahmed, would you like to go ahead and ask your question?
Yes, hi.
Yeah, we can hear you, Ahmed.
Oh, sorry. Can you hear me now?
Yes, we can.
Yes, hi everyone. I am an epilepsy surgeon from Saudi. So actually the chat box is disabled. I cannot post any question. But thank you very much for the excellent presentation, Dr. Ikeda. I had one question about epilepsy surgery. How often do you see patients over 50 with mesial temporal sclerosis who might need surgery?
That's a great question. A lot of them that we're seeing now are those people who we didn't get when they were younger, and not so much those that have had older onset. We tend to see those much less frequently. It's like mesial temporal sclerosis in the population overall. You're seeing less and less of it, and the older population is no different. And the ones that we are mainly seeing are those that were out somewhere far away and didn't get any referral to an epilepsy surgery center and have mesial temporal sclerosis for a long time.
Thank you.
Thank you. So I guess if anyone else does have a question, Please
I
raise
think
your-
we can enable the microphone if they have a microphone available. Aileen, I can take care of that. If someone
So I
raised their
think
hand, I
you'll
can do
just
that.
have to raise your hand so that we can, or just enable yourself so we can
So-
identify. I'm just trying to see who else has
I
a
think
question. I think there was one.
Victoria Ross
Yeah.
may have
Hi,
one.
can you hear me?
Yes, we
Yes.
can. Thank you.
Okay, I'm an epilepsy fellow at the MNI. I have one question regarding this population in the elderly. Do we have to wait for a second seizure to start anti-seizure medication if, for example, there are significant